Hey everyone and welcome. Let's talk about malabsorption. It's one of those topics that can feel like a total maze of causes, symptoms, and tests. Well, in this explainer, we're going to give you the map. We'll cut through the noise and give you a really clear, high-yield framework that you can actually use, both for your exams and in the clinic. So, let's dive right in.
So, here's our game plan. We're going to start with the basics. What even is malabsorption? Then, we'll build a simple but really powerful way to think about its causes. After that, we'll look at the diagnostic tools you'll use, apply it all to a couple of classic disorders, and then wrap things up with a clinical approach you can start using right away.
All right, Section 1. First things first, before we can even think about chasing down specific diseases, we got to have a rock-solid understanding of the fundamental problem. So, what exactly are we talking about when we say malabsorption?
Now, here's the first big thing you need to get straight. Malabsorption isn't one single disease, not at all. It's way better to think of it as a pathophysiologic state. It's the end result when any part of our incredibly complex digestive machinery breaks down. It doesn't matter if the problem is breaking food down, getting nutrients across the gut wall, or shipping them out to the body. The outcome's the same. It's really just the final common pathway for a whole host of different disorders.
And listen, if there's one clinical sign that should set off massive alarm bells in your head, it's this one: steatorrhea. It is the hallmark of fat malabsorption. The moment your patient describes those classic, pale, bulky, foul-smelling stools that are tough to flush, your brain should immediately scream malabsorption workup. It's an absolutely crucial, high-yield clue you just can't miss.
Okay, so we know what it is, but here's the tricky part, right? There are dozens of potential causes. How in the world do you build a coherent differential diagnosis without getting totally lost? Well, the key is having a solid framework to separate the signal from the noise.
And here it is. Honestly, this is probably the most powerful tool you'll have. You just break the problem down into 3 distinct phases. First, you ask, is the problem luminal? Is there an issue with digestion inside the gut tube itself, like not enough pancreatic enzymes? Okay, if not, maybe it's mucosal. Is there a problem with the intestinal wall, kind of like the damage you see in celiac disease? And then finally, you got to consider if it's post-absorptive. This means the nutrients get absorbed just fine, but they can't be transported away, maybe because of a blocked lymphatic vessel. Thinking in these 3 buckets, lumen, wall, transport, is a total game changer.
So, you've got your framework, you have a suspicion, now what? How do you actually go and prove it? Well, that's where our diagnostic toolkit comes into play. The approach should always be logical, stepwise. You start with the least invasive stuff first. You analyze the stool for fat. You check blood work for any nutritional deficiencies. From there, if you need to, you can move on to more specific functional tests that really probe where the defect might be. And then finally, if you're still not sure, endoscopy lets you get a direct look and, most importantly, get that tissue biopsy that can give you a definitive diagnosis.
Now, here's a classic test you absolutely have to know: the deoxylose test. The beauty of this test is in what it tests and what it doesn't. See, deoxylose is a sugar that gets absorbed directly by the intestinal wall, no pancreatic enzymes required. So think about it. If a patient can't absorb it, that points you straight toward a mucosal problem like celiac disease. But if their absorption is normal, well, the mucosa is probably fine, and you should start thinking about a luminal cause, like pancreatic insufficiency. It's a really elegant way to differentiate.
Another key tool is the hydrogen breath test. This is pretty much our go-to for diagnosing small intestinal bacterial overgrowth, or SIBO. The principle behind it is actually super simple. Humans, we don't produce hydrogen gas, but bacteria, they sure do. So if we give a patient a sugar and then we detect a big spike of hydrogen in their breath, it's a really strong sign that bacteria are overgrown way up in the small intestine, fermenting that sugar where they just shouldn't be.
Okay, theory's great, but let's make this real. Let's put our framework to the test with 2 extremely high-yield disorders. By comparing small intestinal bacterial overgrowth and celiac disease side by side, we can really see how these different problems show up in the real world.
And here we go, this is a perfect contrast. You can see how SIBO is a classic luminal problem. It's the bacteria getting in the way of digestion. Celiac disease, on the other hand, is a classic mucosal problem. The intestinal wall itself is being attacked. And this difference shows up beautifully in the labs. With SIBO, you get that classic paradox: high folate because the bacteria make it, but low B12 because they eat it up. With celiac, the big telltale sign is that IgA anti-TGG antibody. Recognizing these distinct patterns is absolutely essential.
When you're doing an endoscopy for suspected celiac, you might see some of these classic visual clues like scalloped folds or fissures.
And this is so critical to remember, you can't trust your eyes alone. These findings have low sensitivity. The duodenum can look perfectly normal, even in really severe celiac disease. And that's why the rule is absolute. If your clinical suspicion is high enough to scope, it's high enough to biopsy. Always, always get the tissue. So, where do genetics fit into all this? This can be a point of confusion for a lot of people. We don't use HLA typing to diagnose celiac disease, mainly because tons of perfectly healthy people carry these genes. Where this test becomes incredibly powerful is in its negative predictive value. If a patient tests negative for both HLA DQ2 and DQ8, you can be nearly 100% certain they do not have celiac disease. So it's not a tool to rule it in, it's an amazing tool to rule it out.
Okay, we've covered a lot. The definitions, the framework, the tools, some key examples. In this last section, let's just boil it all down into a simple, effective approach you can actually use when you're with a patient.
Ultimately, managing this stuff well comes down to one thing: getting an accurate diagnosis, right? Giving antibiotics to a celiac patient isn't going to work. Putting someone with pancreatic insufficiency on a gluten-free diet won't help. The treatment has to match the cause. So whether it's enzyme replacement or antibiotics or dietary change, that structured workup we've been talking about is your path to getting the patient on the right therapy.
So, I want to leave you with this. The next time you're faced with a patient with chronic diarrhea and weight loss and malabsorption is on your mind, just stop. Before you order a single test, just ask yourself this one simple question. Is the problem in the lumen, the wall, or the lymphatics? That simple framework will organize your thinking, it will guide your workup, and it will lead you to the right diagnosis. Thanks for joining me.